format is I'll run through a talk discussing different types of hip replacements, discuss anterior hip replacement, some of the advantages, all of that stuff. We'll go through a few other things, and then we'll open it up for about 20 minutes of questions and answers at the end if you have any questions. So we'll get going. Oops. Okay, just a little bit about myself. I began here at Northern Virginia in 2009, so many years ago now. I specialized in hip and knee surgery. I did a fellowship training, which is advanced training in joint replacement, before I started about 18 years ago. At this point, I pretty much just do hip and knee replacement. High volume hip and knee replacement specialist. I do about approximately 1,000 joint replacements every year. And so I do the most in Central Virginia. And I also have some leadership positions with Northern Virginia. I serve on the board of directors for the Central Region, which is the Richmond region. And also, Northern Virginia is a statewide organization. We have surgeons in Northern Virginia, Lynchburg, Virginia Beach. There's a state board of directors, and I sit on that to help oversee the entire state. And here in the Central Region, I'm the chairman of the board and help lead from a physician standpoint. So let's talk a little bit about some of our objectives for tonight, what we want to accomplish in our talk. In order to understand about hip replacement, we have to understand a little bit about hip anatomy. Okay, so we'll go over hip anatomy. We'll talk about what exactly is a hip replacement. So when someone says they're having a hip replacement, we're having AV difficulties. We'll get there. When someone says they are having a hip replacement, what exactly are they talking about? So what is a hip replacement? We'll talk about some of the different techniques, ways you can do hip replacements, what are some of the options, and then I'm going to spend some time talking about the minimally invasive anterior hip replacement, which is a muscle and tendon sparing approach to hip replacement, what some of the advantages and recovery expectations could be with that. So let's back up and talk just about hip replacement in general, the history of it. First hip replacement ever done was done in the UK. Dr. John Charnley did this in 1962. So it sounds like we think that hip and knee replacements have been around forever, like people were getting these at the time of the Civil War or something. Really, it's only been in the second half of the 20th century that people started having true joint replacement surgery. So 1962, John Charnley, the very first hip replacement. This is an example of a Charnley-style hip replacement. That's it. So the early hip replacements that Dr. Charnley and those he trained did were done through what's called a posterior approach, an incision through the buttock area here. And then they would actually cut off the top of the femur. So they would cut off this bone here, which had muscles attached to it, and flip it out of the way to gain access to the hip. Perform the hip replacement, and then at the end there was this array of wires that was holding it back down and hoping that this fragment would heal. But this was revolutionary at the time, and people suffering from hip arthritis, this was a game changer for them. So this was the very beginning of hip replacement surgery, not that long ago. So let's talk a little bit about hip anatomy. What exactly is the hip joint? You've probably heard the hip joint is a ball and socket joint, and that is true. So if you look here, here's the pelvis, okay? So the human pelvis is here. There is a cup on each side of the pelvis called the acetabulum. You can see right here. That is the socket of the ball and socket joint. So the socket sits in the pelvis. The ball of the ball and socket joint is really the top of the femur. So your femoral bone is your thigh bone. And as it comes towards the top, it curves, and there is a ball that forms at the top. And this is called your femoral head. You can see it right here. This is the ball of the ball and socket joint. So the femoral head sits within the acetabulum of the pelvis. Each of these structures are covered with thick, white, cushioning cartilage called articular cartilage. On the outside of the hip, there's a fiber cartilage rim called a labrum that goes around. So this forms the basic structure of the hip joint. So when we think about hip anatomy, though, we had those pictures before that were just showing the bones. But that's not really what the hip looks like in real life. In real life, the hip, as you might suspect, is covered with tons of muscle. There's nerves, there's vessels, there's lots going on in this area. So if you were to take the skin off a human hip and look, you would see something that looked more like this. You wouldn't see any of the bones. You would just see muscle. And so that brings up the question, what we'll talk about is when we encounter this in surgery, how do we get into the hip joint? So this is looking from the front, lots of muscles coming from the front. Through the back, what you can see here is this is what you would see if you remove the skin from the back of a human hip. You would see a large muscle here called your gluteus maximus. This is essentially your buttocks muscle, okay? When you remove the gluteus maximus on this side, you can see there are lots of other muscles, the gluteus medius minimus and the short external rotators that sit on the back of the hip. Let's see if we can get the thing to, oh, there we go. Let's see. Okay, so let's talk a little bit about what is hip arthritis. We talk about arthritis, knee arthritis, hip arthritis. What is arthritis? Okay, there's several different types of arthritis. There are some less common types like psoriatic arthritis or rheumatoid arthritis that are mediated through the body's immune system. The most common type of arthritis that we deal with is what's called osteoarthritis, and that's just normal wear and tear arthritis that you see that occurs. It's age-related. It can be related to the shape of the hip. It can be related to genetics. But the final common pathway is that thick articular cartilage that we talked about before starts to break down. You start to see the loss of that cartilage. And so eventually what you see here in this x-ray, when you come into a doctor's office for a hip problem, you'll get an x-ray typically. What you'll see here is that there's a space between the ball and the socket. And this space is actually not space, it's cartilage. So you just can't see it on x-ray, so it shows up as a space. What you can see here is that that space is gone. So the bone of the femoral head is now articulating or rubbing against the top bone of the acetabulum, the top of the cup. And this is what we call bone-on-bone arthritis. And so when someone says, I have bone-on-bone arthritis to the hip, that's what they're talking about. It's really loss of the cartilage. And so the bones start to articulate together. What you see are things like pain, stiffness, limping. All of that follows from this condition here. So what is a hip replacement? So when we say we're doing a replacement of the hip, what exactly are we talking about? So this is a hip with arthritis. The cartilage is missing. We have femoral head bone rubbing on the acetabular bone. This patient's having pain, discomfort, limping, all of the things you associate with hip arthritis. The solution for that is what's called a total hip replacement. So these are the main components. There's a stem that goes in the femur, anchors in the bone here. Off of that stem, a ball attaches, okay? In the cup or the acetabular side, the bone is cleaned out, and there's usually a titanium shell that has a plastic liner. So when we say that we're performing a total hip replacement, what we're typically talking about is removing this femoral head here, cleaning out some of the bone in the cup, picking an appropriate size metal cup or titanium shell to put in, usually putting a plastic liner into that shell, and then putting a stem, which is typically titanium, down into the femoral bone that bites into the bone. Typically the bone grows into this titanium stem over time, and there's usually a ceramic ball that attaches on top of that. So that's the major structure of a hip replacement. So this is what hip replacement implants look like. This is the stem that goes in the femur. Another type of stem here. The acetabular cup, usually titanium. These components have a porous coating. This roughened porous coating bites into the bone, and the bone grows into that porous coating over time. Within the cup, there's a plastic liner, and we talked about the ceramic ball that mimics the femoral head. Okay, let's talk about just a case that I've had in the past. This is a 58-year-old engineer, came in with several years of progressive left hip pain. At this point, he's limping, has trouble getting his socks and shoes on. When he gets in the car, he has to try to lift his leg into the car. He's debilitated pretty much on a daily basis. This is really affecting his quality of life. He's had one injection of the hip, so cortisone injection, that provided a couple months of relief, and the pain came back. He's tried anti-inflammatories, ibuprofen, Aleve, stuff like that. Helps a little bit. So he made the decision to go forward with hip replacement. So you can see here, he has bone-on-bone arthritis to this hip, early bone spurs forming around the hip. We went in through an anterior approach, did a minimally invasive anterior hip replacement, so removed that arthritic ball, cleaned out some of the bone of the socket, put a metal socket in with a plastic liner, titanium stem in the femur, and this is the outcome here. And he did great. Got back to all the activities he wanted to get back to. He's doing really well with no pain. Let's see. Having adjustment. Maybe you could just do it for me, Aaron. Okay, so let's talk about. Yeah. So let's talk a little bit about some of the surgical approaches for hip replacement. So as we talked about earlier, the key with hip replacement is how do you get into the hip, okay? So the final common pathway of putting the components in is the same. The question is, how do we get into the hip through a minimally invasive, in a minimally invasive way to maximize recovery and decrease things like pain and other problems you can have after surgery? So there's three main approaches to the hip. The first you'll see on the left is what's called a posterior approach. And this is the most traditional approach. This is the approach that Charnley took when he first started hip replacement. And this is an incision basically through the side and back of the hip, through the buttocks. Hey, thank you. So the incision is made through the buttock musculature. The buttock musculature is split in line with the fibers, so you have to open the buttock musculature up, and then you release several muscles off the back of the femur, and you're able to dislocate the hip and do the surgery through a posterior approach. It's a very extensile approach. It works well, but it does involve a lot of violation of the muscle. Another approach is a lateral approach. The incision is made through the side. You still split through the gluteus maximus. And then there's more muscles underneath called the gluteus minimus and medius that are important for what we call hip abduction. They allow you to raise your leg to the side and balance your pelvis. You have to remove those muscles and save the tendon to repair it at the end, and then open the hip capsule and get into the hip from the side. The last approach is what we call an anterior approach. That's what we'll talk about today. That goes through the front of the thigh, and it goes between a natural muscle layer. So there's no cutting of muscle. Basically, when I go in, I can see the muscle layers. We spread the muscle, put retractors in, and we're able to get into the hip without cutting any muscle. And in this approach, I think it's the least invasive way to get into the hip to perform the replacement. So we'll talk a little bit about the posterior approach, the original approach. And this is the approach I learned when I was doing my fellowship training about 19 years ago. This is still how the majority of hip replacements in the United States are performed. There's still a lot of these performed in Richmond, and people can get a good result from this. But we'll go through a little bit about the approach and what are some of the concerns, advantages, disadvantages. So the incision, the patient is placed on his or her side during the surgery. So this would be a setup for a posterior approach hip replacement. The patient's on the side, the affected hip is facing up. The incision would be made along the lateral part and curving back through the buttock through this area right here. We'd split through the main buttocks musculature, the gluteus maximus, and then release or cut the short hip external rotators in order to get into the hip through the back, okay? So the concerns that I have about this, first of all, you can still get a good result with this, and there's a lot of surgeons that still perform this approach. It is extensile. In other words, it's easy to see everything. You can extend it to get to other parts if you need to. And so I think that's why one of the reasons that some people like it is, I think, the easiest way to get into the hip. But it is invasive to the soft tissues. It is difficult during surgery with the patient on his or her side to shoot x-ray to see where everything is. So it's more of a feel versus knowing based on x-ray or fluoroscopy where things are. And also one of the risks after having hip replacement is dislocating the hip popping out of place, which is not ideal. The main way the hip pops out of place is through the back because humans flex their hip forward. We don't really flex our hips back, right? We sit down, we move our hip to the forward, so the hip going out the back is the most common way. Excuse me. And in this way, we're really opening up the back of the hip. So most of the studies would indicate that the risk of dislocation of the hip is higher with a posterior approach than with other approaches. There we go. So this is an anatomic view, just showing incision starting on the side, going back through the buttock, splitting. You can see the gluteus maximus here is being retracted. These are short external rotators that have been cut, avoiding the sciatic nerve, getting into the hip through a posterior approach. Next. Yep. So the lateral approach. Patient is again on his or her side. So the incision is along the outside part of the hip. The gluteus maximus muscle is still split in line with its fibers. And then what we call the hip abductors, the gluteus medius and minimus, are detached or cut off, released from what we call the greater trochanter, the bone you feel on the outside of the hip. And they're tagged and repaired at the end of the case. So my concerns about this approach, again, you can still have a good result with this approach, but my concerns would be splitting through the gluteus maximus, so it's invasive to the soft tissues. It is also, again, difficult to shoot intraoperative fluoroscopy during the surgery to see where the components are, to check things like the length of the leg, is the stem the correct size, is it in the correct orientation, is the cup oriented correctly. These things are based on just feel and visualization, looking into the wound versus objectively looking at it on a fluoroscopic image. And also, there's a concern about when you release those tendons off of the bone and you repair them at the end, they have to heal. And there's multiple cases and reports about when the tendons do not heal, you can end up with a limp and other problems from that. So that's a concern with the lateral approach. So the muscles here, the gluteus minimus and medius, these are the muscles that are detached in part from the outside of the femur, and then at the end, this has to be repaired during the lateral approach. Okay, so we're going to talk about the anterior approach. The anterior approach is going through the front. Okay, so in this case, the patient is on his or her back during surgery, lying what we call supine on a specialized table. I'll show you an image of it in a second. This approach is completely muscle sparing, and it utilizes a natural plane between the tensor fasciae lata and the gluteus medius, and between the sartorius and the rectus femoris, which are muscles in the front of the hip. So we're going between those muscles rather than through the muscles. The incision's on the front of the thigh, just off to the side of midline. The patient, as I said, is supine, and I'll show you a picture of the table in a second. And during surgery, because the patient's lying on his or her back on the specialty table, the table is what we call radiolucent. So when we bring the fluoroscopy machine in, we can shoot through the table. So we can therefore check and look. We can get x-rays real time, take x-rays before surgery, during surgery, after we put the implants in, line everything up, measure, look. If the stem looks too small, we can go up a size. If the cup is not in the exact position, can change it. I would say that when I do hip replacement, I probably make an adjustment or change something based on the fluoroscopic feedback probably half the time. So half the time, I'll look at the cup and say, it's not exactly where I want it. I'll just change it a little bit. The stem might not be quite the size I want or the orientation I want. I'll change it. The leg lengths may be off, so we'll adjust things. So I'm constantly using that feedback to try to get things exactly where we want to have them. So in my view, the potential advantages of an anterior approach is that it's muscle sparing. I think it's minimally invasive. I think there's quicker functional recovery in the first 3 months in my experience. I think at a year out, it probably doesn't make a big difference, but I think in the first several months, I do feel like the patients with the anterior approach do better. I think there's less risk of dislocation, and the big thing for me, along with all of those, is the reduced risk of errors with component placement, leg length, what we call offset, like how wide you make the hip. All of those things really matter, and having objective data during the surgery to make the decision, I think really helps a lot. So what are some of the risks? Every approach, everything has good and bad, right? So what are some of the potential risks? I mean, with any surgical approach, the risk of bleeding. Almost everyone, when I do an anterior approach, they have some numbness around the incision. That's the same with most incisions. If you have a total knee, almost everyone has some numbness on the outside of the knee. But the lateral femorocutaneous nerve comes right on the front of the thigh, and there's always a few fibers of it that we have to take. So most people have some numbness around the incision. There's a risk of fracturing the greater troch. I've had that happen maybe a couple times. I've done thousands of these. So it's a low risk, but it can happen. If it happens, patients generally heal relatively well, but it's a risk. And when you rotate the leg, there is the risk of getting an ankle injury. Okay, so I've had patients have like equivalent of ankle sprains or like little fleck fractures off. Again, much less than 1%, but it is a risk. There's risk anyway. Whenever we do a hip replacement, we have to dislocate or expose the hip. So going through the back, when you rotate, going through the posterior approach, when you rotate the hip, there's a risk of having a femur fracture. I've seen that happen once or twice. It's low risk, but it's possible. Okay. So this is a picture of doing the anterior approach on the specialized table. So there's this outer space looking table with the patient in these ski boots. All of these leg holders are radiolucent. So they're made out of a carbon fiber, so they don't show up on x-ray. You can shoot right through them. And so, therefore, when you're doing surgery, we're able to get images like this. and we can draw lines. I can get the assistant to rotate the leg at the end so we can get a look at the stem in multiple different orientations. We can look at the cup, say, okay, is the cup where we want it? Do we want the cup to be in a little more? Do we want it to be tilted up or back or forward? Yeah, all of those adjustments can be made based on the feedback from the x-ray. So my personal journey with doing hip replacement is I only did the posterior and lateral approach total hips during my training in residency and fellowship. I began practicing in 2009, did only the posterior approach, did my first anterior approach hip when 2011, and pretty much fully transitioned to that in 2012. And at this point, I've done about 4,000 anterior hip replacements. So I have a pretty vast experience with it, and I think patients have really benefited from that. In my personal experience, I think when patients have had one hip done through a posterior approach, one through an anterior, the vast majority, not all, you can never say 100%, but the vast majority prefer the anterior approach. I think with the anterior approach, there's a trend towards quicker recovery, less postoperative pain, patients mobilizing more quickly in general. And I think I have noticed a significant reduction in errors, as we talked about, of component placement, leg length, offset. When you can actually check x-ray during surgery, you know what you're going to have at the end. There's not a surprise at the end. So when I get x-rays in the office, I'm never surprised because I know exactly how it looks because we checked it during surgery. Okay, so we have a video with just several patients who've had just talking about their experiences with hip replacement a little bit. So it's about 5 or 6 minutes long, so we'll play this, and then we have a few more slides, and then we'll have time for question and answer. Yeah, sure.
They need to turn the light down.
It's a 66-year-old gentleman.
Can we turn the lights down, Aaron, or no?
Invasive anterior hip replacement at the Outpatient Surgery Center went on the same day. So, how was your experience with the surgery?
I thought the experience was great, almost every aspect, in and out. Not a whole lot of work or questions, and I enjoyed basically getting it done quick.
How has this surgery impacted the quality of life?
Tremendously. Before I went in for surgery, I was having trouble putting my socks and shoes on. I've been in pain for a couple of years. And since the surgery and since the healing process, it's like almost anything like before pain started.
And what is your pain today?
I haven't been no pain for the last 10 days.
Awesome. Let me just see if you could walk across the room for us.
So this patient, for those of you who can't hear, is about 6 to 8 weeks out.
Awesome. Well, I'm glad you're doing so well, and thanks for agreeing to make this video with us.
Thank you.
So we're here today with Kira, who is about 2 months out from a left minimally invasive anterior hip replacement she had at our Primo Surgery Center and went home the same day. How are you doing with pain, Kira?
I'm great. I have no pain. I have occasional soreness, but went from being about like a 9 or 10 on a daily basis to 0 at max, like a 1 pain level.
Awesome. So as far as getting back to activities, is walking and other things improving a lot for you?
Improving a lot. I'm able to walk without any difficulty, without limp. Doesn't matter how far I walk. I'm not getting fatigued anymore or feeling like I need to sit down at any point.
Awesome. And as far as your experience having surgery and going home the same day at the Outpatient Surgery Center, how did that go?
It was great. It was really convenient to be able to go home the same day. I got there early in the morning. We were home by mid-afternoon, so it made it a really easy day.
You didn't have any trouble getting up and walking right after surgery?
Nope.
Okay. Can we just see you walk across the room now? 2 minutes out. Good. Great. Well, I think you're doing great. I know your goal is to get back to doing some soccer next year, which I think we can do. And we appreciate you talking to everyone. Thank you.
Thank you. I'm here today with Mr. Payton. He's about an hour out from an anterior hip replacement. How are you feeling?
Wonderful.
Yeah. Can you show us how you can do a heel slide? Just slide your heel up, bend your knee. Yes, sir.
So he's just come out of surgery at our surgery center upstairs.
How's that feel? Okay? Yeah, no problems. Yeah, do one more if you can, please. That's awesome. Great. Good job. Feel okay doing that? Yeah? Any pain? Just a little? Okay, good. All right. Well, thank you.
So this is how we get patients up about an hour after surgery, start on a walker. He's up with a therapist. They discuss his home situation and how he needs to climb stairs. They start working with him on how to get upstairs, and so they'll adjust the climbing to what the patient has at home, make sure the patient feels comfortable with what they need to do.
All right, we're here today with Mr. Melvin, who is about 3 months out from a minimally invasive anterior hip replacement on his left side. We did it at our outpatient surgery center, and he went home the same day. So could you tell us about your experience at the surgery center, Mr. Melvin?
Absolutely. Everybody was so professional. It was great.
And you were able to get up and walk right after surgery?
Yes.
And climb stairs?
Yes.
And I believe you were home within a couple hours after surgery, correct?
Correct.
All right. How is your left hip feeling today after going through things?
3,000.
I'm glad you're feeling better. Now, we knew the right hip was a problem before that as well, and we're going forward with fixing the right hip in a couple months, again at the outpatient surgery center. Well, I'm looking forward to getting that fixed for you and getting you back moving into all the things you want to do. I'm glad you're doing so well.
I appreciate it.
Okay. So today we have Mr. Steve, who is about 2 months out from the invasive anterior hip replacement he had at the Boulders Ambulatory Surgery Center. How was your pain today, Mr. Steve?
Non-existent. Night and day, whatever.
How's the pain compared now to before your surgery? Can you explain how your pain was before the surgery and how you are now?
My pain before was excruciating, pretty much constant. It really negatively impacted my life and my family's life. And now I'm able to do everything again with my son, play baseball, do things with my wife. It's truly night and day.
And how was your experience at the outpatient surgery center getting to go home the same day from surgery?
It was great. The staff was very nice to my wife and family and me, and I felt very comfortable there.
Good. Well, we're glad you're doing well. Thank you so much for sharing this with patients.
You're welcome.
So we're here today with Joe, about 2 months out from a left anterior hip replacement upstairs at our Westchester operatory. How are you doing?
I'm doing great. I feel terrific. No pain. I got the movement that I lost, and I'm doing great.
How is your pain now compared to before your surgery?
I really can't say I have any pain other than maybe a muscle or something that hasn't quite, had a bad leg day kind of thing.
Sure.
But other than that, no pain in the hip area.
Great. And how was your experience having outpatient surgery going home the same day at our Westchester Surgery Center?
Well, everybody that I told, they couldn't believe it, but man, it was great. At home, comfy, and
Great.
going up the hole.
Would you mind laying back and just showing other patients your range of motion and straightening all the way out for us? And then are you able to flex that hip all the way up? No pain with that now?
No.
Able to rotate the leg side to side, no problems with that? Very good. Okay. You can sit back up. Well, that's great. And how quickly were we able to get back to relatively normal activities after surgery?
I was walking with a walker for probably 3 or 4 days, went to a cane for less than a week, and I was walking on my own. So the PT was fantastic. But I think the paperwork was for 15 weeks. They released me after 6. Okay. There's nothing else we can do for you.
Well, I'm really glad you're doing so well. Thanks for sharing this with other patients.
Thank you very much. I really appreciate what you've done. Thank you.
Got it. Have a great day.
Okay, so that's just some of our patients. Now, with any surgical procedure, results can vary, but I will tell you that in general, our hip replacement patients are some of our most happy patients. And at the 2-month mark, when I'm seeing a lot of these patients, they're really doing well. It is sore. You have to go through recovery. Joint replacement is not a walk in the park, but I will tell you that a lot of patients have marked improvements in their quality of life when they've been suffering with hip arthritis and undergo hip replacement. So what are some of our recovery goals after doing an anterior hip? We want to see pain controlled after surgery, and we're usually pretty good about that. Most people would say there's not zero pain, but the vast majority of people would say their pain was very well controlled when they left our surgery center. Most people are able to perform a independent straight leg raise in the postoperative area. The vast majority are able to ambulate with a walker and climb stairs within an hour or two post-op, and almost everyone in our surgery center is able to go home within a couple hours. Most patients are off the walker within a couple days to a week or two. I think there's more rapid progress with physical therapy with the anterior hip. Most of our patients return to office-type work in about 2 weeks, and most are driving within a week or two, something in that ballpark. And those are based on averages. Obviously, outcomes can vary patient to patient. And so, long-term recovery expectations, we have a lot of pickleball players and tennis players. We have a lot of people that hike. We have some people that jog. We definitely have a ton of people that snow ski after hip or knee replacement. Golfing is a big one, so lots of golfers able to get back to golfing. And people just want to walk and do things. So things we typically don't do as much after hip or knee replacement, more like contact sports, sports that involve a lot of cuttings, things that most people in this age category are not looking to do. But all of these other things people are able to get back to. So some people ask, why don't all surgeons perform the anterior hip replacement? I think there's several reasons. The exposure can be more technically demanding. It can take more time when you're learning the procedure. Some people are not familiar with this technique during training, and they prefer the exposure. You can see a little better with the posterior approach. And some people just don't feel like the benefit sort of outweighs the effort and everything to do it. I would disagree, but some people don't feel that that's the case. So some people, when they come in to talk to me about their hip, but they say, am I a candidate for an anterior total hip? Basically, almost any primary total hip patient, I think, is a candidate. Probably 99% of the hip replacements I do are through the anterior approach. Potential reasons to not do the anterior approach is revision surgery. Sometimes if you're doing a redo of a hip replacement, you have to be able to extend the incision and get farther down the femur, and that's harder with the anterior approach. If you need to remove past hardware, like there's screws in the pelvis that are in the back, going through the back is probably better. And sometimes in patients, if they have significantly elevated BMI, sort of obesity, and a lot of that weight is in the front, the posterior approach could be a better approach. So one thing that I talk to patients about during these talks is something that I think is pertinent to you guys, and you can talk to your family, friends, or if people ask you, and it's how, when you're thinking about joint replacement, how do you choose your surgeon? And I'm not saying this in any way to say you have to choose me, because I have a lot of great partners. But I think when you're thinking about this, you should approach it in a thoughtful way, right? This is an important decision. So how do you choose to say you're talking to your first cousin who lives in Charlotte, North Carolina? How does he or she choose a surgeon? I think there's been several papers about this looking at outcomes and trying to get some data, some actual objective evidence. And this is a paper that was published in the Journal of Arthroplasty, which is one of the major journals for joint replacement surgeons. And it came to the following conclusions, that the most important thing as far as getting good outcomes is having a surgeon with experience. The more experience you have, generally the better your outcomes, okay? Related to that is volume. The more you do of something, the better you are at it. And so it just follows, and it is true, that typically doing more of something in medicine, and probably in whatever field you're in as well, means that you get better outcomes. And the outcomes do vary. Training matters. So generally, people that have done advanced training in joint replacement typically have more experience, more volume, and typically have better outcomes overall. I think it's important to ask patients that you know about their personal outcomes, their personal interactions with the surgeon. And then the surgical facility matters. So going to a facility where joint replacement is a focus of the facility, a high-volume hospital where a lot of hip and knee replacements are being performed. For instance, at our surgery center upstairs at Westchester, we perform over 1,000 hip and knee replacements a year in that center. So what it means is that the staff, because surgery is not just done by one person. It's not just me and a solo show. It's me and a team, right? There's a scrub tech. There's people sterilizing the instruments. There's people opening the trays. There's circulating nurse. There's recovery nurses. There's pre-op nurses and anesthesiologists. all of those people are helping take care of you during the surgical episode. And the more repetitions they have, the more practice they have at that, the more we have established protocols, the more we have best practices, generally the better outcomes you're going to have. So going to a facility where that facility is performing 25 joint replacements a week versus a facility where they're performing 1 joint replacement a week, there's objective data that there's a significant difference in outcomes, risks, and all those things to patients. So those are all things to keep in mind when you're thinking about, okay, I need surgery. How am I going to choose a surgeon? Because a lot of people think about, people tend to think this way about professions that are outside of their own. So in your own profession, you understand the importance of different skills and abilities, right? But if you're thinking about building a house and you just say, well, I'll just get any contractor, just whoever pops up, you're the plans, just build the house. You're not always going to get the same result. And the question is, in joint replacement, what could go wrong? And the answer is a lot can go wrong. So, in hip replacement, if the cup's malpositioned, you have a higher risk of dislocation. If you don't check the leg lengths, you can have a significant leg length discrepancy. If you don't get the femoral stem correct, the femoral stem can subside and loosen. There's a lot of things that can go wrong. So I think it's important when you're thinking about these decisions, whether it's hip replacement, knee replacement, or really any surgery, this could go not even outside of orthopedics, to think about the fact that you want to check around, you want to follow those parameters, because I think those parameters hold even if you're talking about cardiac surgery, right? Experience, volume, repetition, facilities that do a lot, advanced training in that specialty, thinking about those things and looking into who's doing your surgery. Next slide. So we're going to talk about just 2 things real quick, 2 cases that demonstrate a little bit to my point. So this is a 52-year-old female. She came to see me with left hip pain. She'd had a past right total hip that was performed in Texas. Okay, so she came because this hip was hurting. This hip was actually doing okay. And so what we talked about, we fixed her left hip. Now, if you look here and you look at this stem versus the stem I put in, I think you can see that this one, it barely made it. It sort of barely made it across the finish line. It grew in, but that stem easily could have broken out of the cortex. I mean, she's walking on it, and it's pushing down here against this bone. So when we put the stem in, we want the stem to go directly down the bone so the load is borne along the longitudinal axis of the bone. What happened here is our surgeon in Texas did not have the exposure, so he wasn't able to see. And so he could only see the top part. And so he just shoved the stem down into varus, and miraculously it worked. But this could have been something that could have been really bad. When I saw it, I was like, man, you're doing okay? She's like, okay. So it worked. But this is an example of something that could easily have been a significant problem for her. If she breaks through that calcar, then we're coming back and the whole thing's coming out. So that's one example. Next slide. So this is a gentleman that came to see me, 61-year-old guy, had bilateral hip pain, had a right total hip that was done in 2018. So I saw him about 2 years ago. His right leg had shortened probably 1.5 inches, so he had buildups on the outside of his shoe because he had such a significant leg length discrepancy. He also has an arthritic left hip, so he's bone on bone here. This hip, there's the cup, looks fine, and what you can see is that stem is sliding down the canal. So as it slides down the canal, his leg gets progressively shorter. The reason it's sliding down is because the stem was undersized. It's a little bit smaller than it needs to be, so it didn't get good bite into the hard cortical bone. So we talked about it, and we said, well, let's fix the easier problem first. And because this had been such a poor experience for him, it was like a year-long recovery. He was on a walker off and on. So we said, I think you'll have a better experience on the left. Let's fix the left hip. So next slide. So we did his left hip. He actually recovered quite well. We did outpatient. He was very happy, much different experience than he had on the other side. So in this case, the component is well fit, so it's filling the bone, it's getting good bite, and it's very stable, which means that he can weight bear right away. And it feels a lot better than if it's not well fit, because if it's not well fit, it's going to hurt a lot more because it's not stable in the bone. So after that, we said, well, let's maybe think about fixing this hip over here because your legs are still about 1.5 inches different and you're still having pain on the right side, and that stem is progressively each year just going a little bit further down in the bone. Okay, so next slide. So I went in and we took the old stem out, left the cup, and did a modular stem that goes farther down and bites into the bone here, lengthened the leg back out. Now his legs are about the same length. And I actually talked to him about a month ago, and he's doing great, so he's feeling a lot better. But these are just some examples of some things that can go wrong during surgery. So a little bit about outpatient joint replacement. I've alluded to it several times throughout this talk. Back in, say, before 2021, there was almost no outpatient total joint surgery being done in Richmond. At this point, it's the majority of my practice, so I think we've gotten a lot better with regard to surgeon techniques, doing minimally invasive surgery. I think the anesthesia has gotten a lot better. Our anesthesia team that we have both at our Boulder Surgery Center and our Westchester Center are outstanding as far as doing preoperative blocks and really trying to help patients with things like blood pressure, nausea, vomiting after surgery, all of that. They've really done a great job with. And so we're able to now get patients up and moving and home the same day on a routine basis in a safe manner, which has been a game changer for patients. They really like being able to go home and not being in the hospital. No catheters in their bladder, no blood draws every 6 hours. So we've really been able to get people moving more quickly. We have two main centers. This is a picture of the center you're sitting in, the Westchester Center. We have a surgery center, a 4-room center right upstairs that I think is outstanding. It's where I do most of my surgery now. We also have our Boulder Center, which is over near Chippenham Hospital. We have a surgery center on the second floor. The one here is owned by Ortho Virginia. The one at Boulders is run by HCA and co-owned with HCA and Ortho Virginia. But I personally perform now about 600 outpatient total knees and total hips every year where patients have surgery and go home that day. So in conclusion, why choose anterior total hip? I think it's completely muscle sparing. I think there's evidence for improved recovery, especially in the early stages, the first several months. I do think it's the most minimally invasive approach for hip replacement and has the potential advantages, I think, of less pain, reduced errors, quicker recovery, and a quicker return to the life and the things you want to do. So we want to get you back enjoying your life and doing all the things you want to do. So thank you very much. And with that, if there's any questions, I'm happy to answer those questions. Yeah, sure. Sure, I'd be happy to. Yep. Yes, ma'am.
If I have to spend the night, which one of those places would I go?
So the question was, if you have to spend the night, where would you go? So if we're thinking you need to spend the night, then I would do the surgery at Johnston Willis at the hospital, because the surgery centers are set up to have surgery and go home later that day. They're not attached to a hospital. If there was extenuating circumstance and you just couldn't go home, we could transport you to a hospital, but that's not our plan. So if we're planning on spending the night, we would typically do the case at a hospital setting. In my own personal situation, it would be Johnston Willis, but for some people it might be Chippenham or St. Francis or St. Mary's or wherever.
Do they have that same bed with the x-ray?
They do. They do. They have the Hannah table at the hospital as well. Yes, ma'am. Yes, sir.
By the way, what size femoral head do you use?
So the question is, what size femoral head do you use? And that's a good question. It's based on the type. It's based on the size of the patient and also the type of hip replacement you're performing. So I showed one basic type, but there are other types of hip replacements. For the average patient, if I'm doing a ceramic ball and a plastic liner, I'll use a 36. For patients that are larger and they have enough room, sometimes I'll go up to a 40 ceramic ball. And then if we're doing something called dual mobility, where we actually put a metal liner in the cup, and on the femoral component, we'll put a ceramic ball with a plastic ball on top of it. It has two balls, sort of a ball within a ball. Then that really varies based on the size of the cup. It jumps based on the size of the cup. So the answer is, in most cases, probably a 36, but it can vary based on the size of the patient and the type of hip replacement that we're performing. Yes, sir.
Who makes your hip replacement?
The ones I use are made by Zimmer Biomet. So they're probably one of the Zimmer Biomet. They're probably one of the largest orthopedic companies in the world. There's others. Stryker is a major manufacturer. Smith & Nephew, DePuy. So there's several major manufacturers, but Zimmer Biomet's probably the largest.
What is the process of starting?
I'm sorry, sir.
The initial step you take, you have a somebody we meet with.
Yes, sir. So the question is, how does it start if you are suffering from hip pain? So it would start with making an appointment with a surgeon or surgical team. Like I have 2 physician's assistants that have each worked with me for over 12 years, so we function as a team. So people will see me sometimes they'll see Chris or Amber, but they would make an appointment, come in, we would evaluate the patient, determine if we feel like they're having hip pain, get x-rays, sometimes get an MRI if indicated, and then if it looked like that patient was a candidate for hip replacement, we would have a discussion with them, talk about the risk and benefits, talk about the locations for surgery, and then make a decision on whether we want to go forward with surgery and which location we wanted to perform the surgery. Okay? Yes, ma'am.
Is 81 years old too old to have?
So,
I'm not really in pain, but listening to you, no, I'll tell you, he did my stepmother. She's still recovering, but amazing.
Yeah.
This man is amazing.
Well, thank you very much. So the question is 81 years old too old to have hip surgery? And the answer is no. So we operate on people in their 80s all the time. The oldest patient that I've ever operated on for a hip replacement was 102. So they were 102, and he was in actually great shape, still lived independently, really. And so there's not an exact age cutoff, although as patients do move up in age, I have more of a discussion with them about, listen, as we get older, the risks probably do go up some. And so what should we think about? Should we be thinking about non-operative options that may not fix the problem but sort of help? Or should we think about surgery? People in their early 80s, we operate on all the time. So I would not say in any way, shape, or form you're too old. The main thing that matters is age matters, but also medical status. So patients' overall health, how are their heart and lungs, if they have diabetes or not, is it well controlled, all of those things, weight, things like that. Yes, ma'am.
Does robotic surgery help with the surgery, or there's no robotic surgery hip replacement?
So the question is, what is the role of robotic surgery in hip replacement? And that's something that a lot of people talk about, robotic surgery and knee replacement and hip replacement. So I was one of the first ones in the city using robotics in hip replacement about 12, 13 years ago now. There's a Mako robot we used at Chippenham. Since that time, I've also used the Rosa robot, which are 2 of the major robotic platforms for hip replacement. My personal experience is that it made the surgery more difficult, and it did not really help. Because the main thing that the robot in hip replacement is doing is trying to give you feedback on where the length of the legs, the offset, and also the position of the cup, all of which you can get from fluoroscopy, from those x-rays I was showing you. So in my view, having the robotic arm there, it means that you can't have an assistant standing where you want that assistant to stand for retraction and helping you. And there's also, in my view, the risk of contamination because there's all this equipment now bunched together around the hip. You're leaving the wound open longer. So I've tried multiple platforms, and I have not found it helpful. I do have some partners that are big believers in robotic surgery. In my experience, I don't want to speak for them, but most of them are focusing on the knee with it. There's very few people that I know that are using robotics in the hip just because for the same reason. You have to. So in the Mako platform, for instance, when I was doing it, on the side that we weren't operating on, you'd have to make incisions, drill pins in the pelvis, which is not always very easy, finding the pelvis and drilling pins down into it. So now we have incisions on the other side. We have a tracker there. We have a big robotic arm, all to try to put the cup in the position that we're saying we want to put it in, which I could do by just looking at the x-ray. So I've tried it multiple times, and I just have not found it that helpful to me.
This might just be with knee surgery, but when I went to have my knees done, as soon as they saw me, they sent me to get measurements on my knees, and they had my knees built just for me.
Yeah, so there are, that is, so the question is, do they make custom implants, patient-specific custom implants for hip replacement? And there could be a few places where that's done in very unique situations. I've had custom implants made for revision surgery when we're missing large pieces of bone out of the pelvis. But for primary hip surgery, that is almost, I would say 99.9% of the time, not the case. So I don't know of any custom hip replacements that have been done in Richmond to my knowledge, on a primary hip since I've been in practice, unless the patient had something like maybe dwarfism. So if the patient, had dwarfism or something like that, and it was just so small that standard hip replacements wouldn't fit, that might be a situation, but those are typically done in very specialty places. Yes, ma'am.
Quick question about follow-up recovery with physical therapy.
Yes. So what's your question regarding that?
Do post-operative patients always go to physical therapy? Do you suggest it? And usually about how long, depending upon insurance?
Sure. So the question is, after hip replacement, do all patients go to physical therapy, and how is that handled, and approximately how long do those patients participate in therapy? So I'll give you the example for most of my patients. I refer almost all of my patients to physical therapy after hip and knee replacement. I think with hip replacement, it's probably a little less necessary to go as much as with knee replacement, because knees, you really want to work on that range of motion, and hips, we don't have as much problem with range of motion. So I give all patients the option. I refer the vast majority to physical therapy. If someone's having a second hip done and they feel like, listen, I've been through it, I know what to do, I'm good, then I'll say, well, if you're good, then you can just do it at home. The average person, I would say, in therapy is in therapy after hip for somewhere between 6 to 8 weeks, usually going once or twice a week for 6 to 8 weeks is average. Yes, ma'am.
So post-op, you said driving 1 to 2 weeks. What about flying?
So the question is, after hip replacement surgery, we said that most people are driving within 1 to 2 weeks. And again, that varies from person to person. I've had some people that feel like they're ready. They're not taking any pain medicine, and they're ready after a couple of days. It also depends what leg you're having surgery on, right, for driving. And some people are a little longer. But the question is, what about flying? And so generally, I've had people fly within a week or two of hip replacement. Taking short flights is not that different than being in a car. I counsel them about the risk of blood clots, but everyone in the first month after surgery is on some type of blood thinner. We talk about things like ankle pumps, getting up and moving. In general, I try to tell people that if possible, it would be best not to fly for a month after surgery, if possible. But I've had some people that just have situations where they have to, and we just deal with that. But in general, if we can, probably sticking around for that first month to make sure we're doing well and stuff is a reasonable plan. Any other questions? All right. Oh, yes, sir.
How long? How long will it last?
That's a great question. The question is, how long will the hip replacement last? And so they've made a lot of strides. When we looked at the ones that Dr. Charnley was putting in, and the hip replacements from the 70s, even early 80s, that type of plastic, a lot of them wore out within 5, 6, 7, 8 years. So over the years, these companies have done tons of research and development into improving the plastics and the bearing surfaces. And they've tried lots of different things. Some of them have worked well, and some have been failures, and they end up coming off the market. So looking at the ceramic and the plastic that I was showing you earlier, that plastic is highly cross-linked polyethylene. So they found that putting the polyethylene through low-dose radiation to basically enhance organic cross-linking is really helpful. Another thing that they found is that infusing the poly with vitamin E to stabilize it against oxidation has been very helpful. And so there's good data, I think. So, for instance, I've been in practice now for about 18 years. I've seen 1 or 2 patients with any wear of their plastic in the hip replacements I've put in. So very few, okay? The data would say that there is, in most cases with these newer generation polyethylenes, minimal wear at 15 years. Really minimal wear at 20 years in a lot of cases. So the only way to really know how long components are going to last is to actually put them in real humans and follow them out. The lab data would indicate they can last decades and decades. Okay? When I talk to patients, I say there's good data, I think, to say 20 to 30 years or more, but it could be more than that. For instance, I really haven't seen a lot of wear problems in my own practice. And if you look at a lot of the studies, there's good longevity at even 2 decades out from surgery. So the answer is it can vary patient to patient. We don't know for sure, but it's looking like they're lasting longer and longer, especially compared to the historical benchmark of like 10 to 15 years. Yes, sir.
Do you encourage the shots, or if you just go ahead and do surgery?
The question is, do we encourage things like cortisone injections prior to surgery? We do use a lot of cortisone injections. A lot of times we use it for patients that have like moderate arthritis or patients where we want to try to determine, is the hip the source of the pain, or is it coming from the back, or other cases. In some cases, the patient might be really young, and so we were trying to avoid surgery. So if you came in and say you're 60 years old, you've been limping for 2 years, your hip is completely bone on bone, you've tried anti-inflammatories, I would still offer you that as an option, but I would tell you I'm not sure really what our end game is, because in my experience, it will probably help for 6 to 8 weeks, maybe 3 months, and then we're going to be back at the same point again. There is some data that repetitive injections before joint replacement may raise the risk of infection when you have a joint replacement. So I really don't encourage, when people have severe end-stage arthritis and they're at a certain age, I try to have the discussion. What is our goal here? Maybe our goal is just to get you better to go on that family trip that you have coming up next month, and then you're thinking about surgery in 3 or 4 months from now. That's a reasonable goal. But if it's like, I'm just going to see if I can fix this with injections, that's probably not going to happen. Or when I say probably not, it's not going to happen. So I think it's working with the patient and defining their goals. But cortisone injections are not a long-term solution. Yes, ma'am. So the question is, what is the time, if I understand your question correctly, what is the time between surgery if you need both hips done? Typically, I would say the closest I perform them together would be about 8 weeks, somewhere in that ballpark. For a couple reasons. We want the first hip to become strong and to be able to support the patient. We want the patient's blood counts. They're going to lose some blood during surgery. We want the blood counts to build back up to a more normal level. And also we want to get outside of the risk factors for blood clots. So in that first probably 6 weeks after surgery, the risk of blood clots is a little higher. So I would say 6 weeks would be the minimum. I'd probably prefer more like 8 to 10 weeks. Yes, sir?
I'm sniffing on your Biomet hip femoral head you have. Are there any other femoral heads out there anymore, or basically they're all now plastic?
So the question was, what types of femoral heads are on the market? The majority of the ones being put in that I'm aware of in Richmond are ceramic. Now, there are still cobalt chromium metal femoral heads that are used in certain situations. You need a neck length that the ceramic won't allow, and so a metal head might be used in that case. But for myself and many of my partners, I think the trend has been more towards ceramic in the market right now. Yes, we'll go. Okay, we'll go here, and then you. Yes, no, you can go ahead.
All right, if you have arthritis in your hip and you get that fixed, but if you're prone to arthritis, are you going to get arthritis in your knee?
No, not necessarily. Some people just have hip problems. Yeah.
Okay.
A lot of arthritis in the hip can be based on how the hip is shaped. So the socket might be a little shallow. The socket might be too deep. The femoral head may have bumps on it that sort of where the ball bumps into the cup over time. So the morphology of the hip plays a really important role in the risk of developing hip arthritis. And so in many cases, that may have no impact at all on your knees. So there are some people that have both hips and both knees replaced. They have arthritis in all 4 joints. And there's tons of people that might have both hips replaced and never have a knee problem. So it doesn't mean just because you have hip arthritis, you're going to develop knee arthritis. There's some people that might just have a right hip and their left hip is fine. I would say if you have arthritis in one hip and require hip replacement, the risk of having developing arthritis in the other hip and requiring replacement is definitely elevated, but it's not 100%. Okay? And yes, ma'am, So how long does surgery take? I usually tell people approximately an hour. It's about an hour of surgery. There's some pre-op prep time before getting the patient on the table, position, prep, drape, and there's some time afterwards, like getting the dressings on, getting off the table, getting to recovery, but the actual surgical time is about an hour. Yes, sir?
What are the restrictions afterward? So you said no contact sports.
Yeah.
You can't go to the NFL.
Yeah, no, NFL is out.
But marathons,
yeah, so
squats, leg press.
Right. Those are good questions. So the question is, what are the restrictions after hip replacement? We talked about things like contact sports aren't a great idea. Most people with hip replacements are not looking to return to that. But the question was, what about things like marathons or heavy weight squats? So I tell people that in general, the hip replacement, think of it like the tires on your car. It can go really fast, but the harder you drive it, the more you risk wearing it out. So the more in the wear studies, we do know that the number of cycles matters. And so repetitive impact activities, I generally try to steer patients away from. I still have patients that run after hip replacement, but I encourage them, maybe marathons aren't the best thing. And maybe thinking about cross-training also with some running, but also elliptical, swimming, cycling, non-impact activities as well would be a good idea. But yes, can people run? Yes. Like weightlifting. I don't really encourage people to do heavy squats. Can you still squat and do some weight? Yes. But if you're a big weightlifter, squatting 300 or 400 pounds and putting that stress across the implant, those are things we just don't know how it's going to affect the longevity of the implant. Yes, sir.
I have a stainless steel hip that I've had since 2009.
Okay.
I've had 2 revisions due to infection. Now it's starting to give me trouble again, and I have to take amoxicillin twice a day because of a danger of infection. Is that something that you could handle?
Well, the question is, what you're describing, he was saying he's had a hip replacement in 2009, has had multiple infections, and now is on antibiotics to try to reduce the risk of having an infection. So in that situation, that is a very complex situation. Do we deal with situations like that? Yes, but there's not okay, go in and do one procedure and potentially fix this. Having chronic infections, especially after multiple surgeries, is a hard problem to solve, and so that would require a more detailed discussion than just saying, oh yes, come next Tuesday and we'll fix it up. So that is a more challenging situation. It's something we handle, but yes, it would require a much more detailed discussion. So I really appreciate you guys coming out tonight. Thank you very much. I appreciate you guys coming. Just a few words about Ortho Virginia. I'm one of the surgeons here. I have a ton of partners who are great joint replacement surgeons as well. We also take care of patients for hand problems, spine problems, foot and ankle problems, sports injuries. We have a ton of doctors that do a sort of pain management for back pain, injections, things like that. So we really want to take care of all your musculoskeletal needs. So if you have those things, please check out our website, and I think we have someone that could help you. So thank you very much.